We're going to start the panel discussion part of the evening. So we have three of our four guest speakers up at the front here. I believe Dr. Levy had to leave. But again, just to remind you, we have Dr. Pike, Dr. Tulloch, and Mr. Lefebvre over here. So you can direct your question to any of them or all of them. And I'm sure there will be lots of great questions. So we'll just, if you'd like to just stand and ask your question, if you are soft-spoken and you'd like to have the microphone, just let me know. So, any questions to start?
Hi, I'm Dr. Samra. I'm one of the family physicians at the Family First Health Center, and we're part of the Ottawa model, and we're doing, we've become members of the program. Basically, for all people here, what we do is patients come in, the receptionist asks them if they smoke or don't smoke, so automatically kind of the first form is there. And then they usually fill out a form, and subsequent to that usually would meet a nurse where they go through kind of a dedicated assessment that's pretty standardized across the board. Then they usually see me right after, and then they kind of follow up with the automated kind of system. We've just kind of been in, I think we've had one evaluation, kind of the 6-month period. I'm just wondering, in terms of the other clinics that maybe have been doing it longer, or those long-term, what has that been showing with you guys in terms of results, in terms of how effective, how efficient it's going, how much better maybe the results are than just the old-fashioned way in terms of doctors, doing that counseling and such?
Thank you. Thank you for a great question. So we do have good data because we did a number of pilot studies around our Champlain region and family health teams and other family health groups. And this has been led by Dr. Sophia Papadakis, who's not with us tonight, but who's, I keep calling her a guru on smoking cessation in the primary care community. But we know that when family practice units like yours apply these kinds of principles of being very systematic, identifying, making sure that every single patient that's a smoker gets an offer of assistance, and then following them for up to 6 months and making appropriate use of the pharmacotherapy and so on, we can triple basically the effectiveness of the family, of the processes in that family practice setting. And so this is a very substantial improvement. And when you think about the fact that 75% of Canadians see a primary care practitioner once a year, it is said, the impact of family practice units, teams, groups, clinics, being very systematic about helping smokers is going to have a very powerful, pronounced public health impact. So I congratulate you and your colleagues at the Family First Health team, because you're leading the way and doing something very innovative and something very significant.
So in just in terms of the pilot, how many, would you say that's kind of a year or 2 years usually when you really see those results type thing? I'm just curious, because we did the 6-month and it wasn't as good as I would have wanted it to be.
So, and this kind of is getting really sort of researchally maybe oriented, but we do not report, nor would we ever be able to publish in the scientific literature any evidence about smoking cessation unless we had data that was at least 6 months in duration. So until a person has been smoke-free for 6 months, from a scientific and a research perspective, we still continue to consider them as smokers. So the data that I've talked about in terms of tripling is following a group of smokers for 12 months. And so that's 12-month data. And comparing what happened in a clinic before we introduced the program, and then comparing what happened in the clinic after we introduced the program. And now those results are going to vary immensely. They're going to vary depending upon where the clinic is. They're going to vary depending upon the socioeconomic status of the patients that are seen in that clinic. Smoking is very much tied into levels of education, socioeconomic status, and so on. So those are going to have an impact on our eventual cessation rates.
Thank you.
Thank you for a great question.
All right, another question? All right, I'll pose one to Dr. Tulloch if I can. If someone has a mental illness or any other addictions, for example, alcoholism, what is the likelihood that that person would be able to quit smoking? If they're a smoker, they have an addiction to alcohol, mental illness along with that. There's a combination there, so what are the likelihood that that person would be able to quit?
I mean, we always would say it doesn't matter. If a person has a mental illness, we absolutely would continue and encourage them to quit smoking. We would never change the protocol per se or how we might intervene with them. We absolutely encourage them just the same way. We would monitor closely just because anyone or many people do when they quit smoking tend to have some symptoms like depression, anxiety, whether they have a history or not. So we just monitor. And so they do have a difficult time because, as Dr. Pipe had mentioned in his presentation, there is sort of a hardening of the population, is what we're saying. So a lot of people, if we looked 40 years ago, we had a much higher rate of smoking in Canada than we do now. And so many of the people that did quit were ones that were probably less addicted, less comorbidities like mental health or other physical health problems. And so those individuals are now sort of the easy ones, would it be a little bit, or are now already smoke-free, and those with mental health issues are having a little bit more difficulty, but we can still absolutely help them and they can still be successful.
Just a quick comment, if I may. We know that the life expectancy in Canada of people who have significant psychiatric conditions is 25 years less than that of other Canadians. That is scandalous. That is something the public has no appreciation of, and it doesn't get talked about in the media. There's a message for you. And the vast majority of that 20 to 25 year discrepancy is accounted for by tobacco-related diseases. And so our psychiatrist colleagues are now much more involved in trying to help their patients stop smoking because they recognize that it will be tobacco which will kill and cause unnecessary suffering and morbidity as opposed to psychiatric illnesses. And you can continue to manage those psychiatric conditions while you help people stop smoking.
Any other questions? Yeah.
So I work with two physicians, and they both have mentioned to me recently that they have two patients they would like to refer to smoking cessation programs. However, I know the University of Ottawa Heart Institute requires that they smoke at least 10 cigarettes a day, but they smoke less. Is that no?
So we have two studies going on right now, and the studies require that the person smokes 10 cigarettes or more. But the quit smoking program, I'm going to look at Deb to make sure I'm not speaking out of turn here, there is no minimum. So they can absolutely attend that program. We're all together.
613-761-5464. Operators are standing by to take your call. You are self-referred. You will speak to talented electric nurses who will help you with your smoking cessation challenges.
Yes, at the back of the room there.
Manageable. I had nausea in the morning when I was feeling nauseous when I had breakfast in the morning. I don't remember anymore. I think it takes that. I don't remember when I took the drug. I just remember being nauseous in the morning, and I remember strange dreams. Nothing scary, but kind of strange dreams that you remember when you get up in the morning. Those are the only side effects that I remember from being on shantons.
I'm going to be a real nuisance, but if I can add to that, the reason why people who take Chantix and also many other smoking cessation medications have strange, and often many individuals find these quite pleasant and quite intriguing, is because if they're not a nighttime smoker, their nicotine receptors in their brain are being stimulated during the night by the medication which is in their body. I mentioned if they're not a nighttime smoker, many of the smokers that we see today actually smoke during the night. And most people have no idea that people smoke during the night. But if you ask people about this, they will tell you, so you say, do you smoke during the night? Well, I get up to go to the can, so I figure I'm up anyway, and like, I'll have a drag or two. Well, how often does that happen? Oh, maybe 4 or 5 times a night. And this is, again, indicative of just how addictive this substance is. And the reason that people get nauseated with many of these medications or with NRT is that you have nicotine receptors in your gut, as well as in your brain and other places. And so when those receptors are stimulated by this medication, that's when you get nauseated. In exactly the same way, if you chew the nicotine-containing gum very aggressively and swallow the saliva, which is now laden with nicotine, it'll stimulate those receptors and get nauseated. So there's some very simple ways that you can avoid this, and for the most part, it's taking the medication with a meal with a full glass of water.
wonder where I fall.
Dr. Pike, maybe you can, if I can just go along those lines, is there a chance of overdose if you're on, let's say, the gum and the patch? Is there a chance that you could take too much medication to try and stop to quit smoking?
Smokers titrate their nicotine with exquisite precision. And you know, I couldn't help but recall what Fabian said. You know, I used to put the patch on, and then, geez, I still wanted to have a smoke, so I figured I'd take it off and have a smoke. Well, what he's telling us, if you think about it, is that with the patch on, he still wanted to smoke. He wasn't getting enough nicotine to satisfy his particular requirements for nicotine. And so if you increase the dose of nicotine by increasing the number of patches, you'll eventually eliminate that craving for nicotine, and an individual won't want any more. There are lots of intriguing little stories of individuals who've turned up at emergency departments having made what they thought was a suicide attempt, and they've got 96 patches all over their body, right? And guess what happens to those individuals that have 96 nicotine patches all over their body? They get nauseated because but nothing else happens to them. And irrespective of how much nicotine you use in a patch and the inhaler and the gum and so on, you're never going to come close to the amount of nicotine you would be receiving by continuing to smoke.
Next question? Yes, right here.
How do you separate, like in your field of study, how do you separate cigarettes from the list of other drugs that you noted up on the screen earlier? And yeah.
So that data that I showed was not from our research, that was from other researchers that actually appears in a textbook of psychopharmacology. So researchers assessing that would interview large numbers of individuals who had minimal exposure to each of those drugs, and then identify what proportion of those individuals ultimately became addicted. And that's how they would derive those particular figures. Now, it can become a little bit complicated in your question, I think, reflects this. There will be people who are co-addicted to a number of these substances. But there again, the literature tells us that those individuals who may be abusing alcohol, abusing cigarettes, abusing nicotine, abusing other drugs, will generally find nicotine the hardest drug to address.
Yes, at the back.
Thank you for this awesome information. My question is, I'm curious to know if any of these drugs are in the direct contradiction with the alcohol or other substances that people are in.
So if I heard, and I'm getting really old now, so I have difficulty hearing in bars, does NRT interact with other drugs, with alcohol and other drugs? Is that? Oh, any of the other smoking cessation medications?
Yes.
Thank you. Excellent question. Well, interestingly enough, we recognize now that just as it may sometimes be necessary for us to use 1, 2, and sometimes 3 medications to control an individual's blood pressure, or 1 or 2 or sometimes 3 to get lipid levels down. And we're very vigilant in terms of doing that because we know the risk that's represented by having uncontrolled high blood pressure or uncontrolled high levels of cholesterol. We now recognize that many smokers will benefit from 1, 2, or 3 of these medications. So that in combination, so that our colleagues at the Mayo Clinic, for instance, have published on the effectiveness of combining NRT, nicotine replacement therapy, with a medication like bupropion, which we didn't talk very much about, but which stimulates nicotine receptors. They've also published about the combination of NRT with varenicline, which is the most recent addition to the medications. And I know that they are about to publish, or they have data on the combination of all 3 of these medications. And that can be particularly helpful in patients, and we often don't think of this, but there are people who smoke 5, 6, 7 packs of cigarettes a day. And these are very, very addictive patients. And we know that the nicotine replacement therapy addresses all of the nicotine receptors, whereas the medication called varenicline only addresses that one receptor which was in that diagram. And so individuals who take that medication may sometimes go from 3 or 4 packs of cigarettes a day to half a pack of cigarettes a day. And they just can't seem to get down beyond that. And very often the addition of a small amount of nicotine replacement therapy in addition to that medication will help them break free. And the reason is that we speculate, or the speculation is that what's happening is that, yeah, we've stimulated that principal nicotine receptor, but in these very, very heavy smokers, all these other ones are screaming out, in a sense, feed me with nicotine. I'm not getting any nicotine. I'm used to getting lots of nicotine. I'm going to make you feel terribly awful until you get me some nicotine. So you give them nicotine, you quieten them down, and all of a sudden the craving and the withdrawal symptoms go away. So combination therapy is very appropriate in a certain subset of our patients. And people like Debbie Aitken and her colleagues in our institution have become very, very skilled and very, very resourceful in terms of managing medication in these kinds of settings for these kinds of patients.
So can we get access to that nicotine replacement therapy in research?
Well, you can get access to nicotine replacement therapy over the counter in a drugstore or service station. You can buy NRT, but we also use NRT in many of our research studies. Dr. Tulloch is doing she won't like me saying this, but it's probably one of the world's largest studies in smoking cessation in terms of what we call a real-world population. Not just people who are free of this disease and free of that problem and free of this issue, but people who really reflect smokers in the community. And she's using NRT and a variety of other medications in that study.
Next question?
Can I make a little plug? There are sheets at the back regarding the study as well as a quit smoking program. So if anyone wants further information for both, you can feel free to look at the back.
Yeah, go ahead.
So I'm working on a study right now where we're preparing a clinical trial application with Health Canada to go above the 21 milligram dose for NRT. In your, I guess, professional opinion, do you believe the 21 milligram dose is too low for heavy smokers?
Well, absolutely, and we are actually, this is part of our trial, we're doing a study which is using titrated levels of nicotine. So we're increasing those doses of nicotine up to 42 and beyond. So our standard practice at the hospital, and it's great that you're contemplating doing that study because that will add to the literature, but our standard practice at the hospital is if you're a 1-pack-a-day smoker, you'll get 1 patch and the use of it inhaler. If you're a 2-pack-a-day, you'll get 2 patches. And we'll do that within a very short time after your admission. If you're a 3-pack-a-day smoker, we're prepared to use 3 patches. I like to say to my colleagues, as much as it takes, for as long as it takes. And I don't care whether I see patients 12 months after they've started to stop smoking, who come back and say, every time I take this patch off, I get this urge to smoke. And, I've been smoke-free now for 14 months since my heart transplant, and every time I get an urge, to me, it's a no-brainer. Not a problem. You just keep putting that patch on. See you in 6 months' time. And everybody goes, yeah, heart transplant. Right? But if that's appropriate for a heart transplant, that's also an appropriate approach for a 22-year-old young female in your practice. Because the heart transplant patient, frankly, has got a life expectancy which is infinitely less than that of a 22-year-old young woman or 22-year-old young man who's trying to stop smoking.
Do you have any dialogue at all with the government around the legalization of cigarettes or where that's going?
Well, wearing another hat, I think many of us, and there are some in this room who had dialogues with various governments about regulation of tobacco. So I think, though, it's unrealistic to expect that a government will prohibit tobacco while there's still a substantial proportion of the population addicted to the problem. The biggest challenge at the moment for us in Canada is to address and get a handle on contraband tobacco, which is really, really messing up our ability to help thousands of Canadians. And so I think it's very important that particularly our federal government hear that particular message. The country, I would predict, that is probably going to be the likeliest to be the first, and they're actually starting to talk about it, to prohibit tobacco products entirely, I would predict will be New Zealand. Because they're far enough away from any other countries that smuggling is not going to be the kind of an issue. They're getting their smoking rates down very successfully and very substantially. And they're doing some very, very innovative, novel things. We could learn a lot from our museum.
What about making NRT more affordable? For some people, it's just simply not something they can afford. Is there any level of discussion with the municipal, provincial, federal governments to making it affordable?
So I would thank you for the question because it's very, very appropriate. Now NRT is available through some programs which are coordinated by our colleagues at the Centre for Addiction and Mental Health in Toronto at no charge. And NRT is available in a variety of family health settings, in a variety of community health center settings. So that's one reason. Secondly, NRT is available, and some of the other pharmacotherapies are available at no charge for those who are on social assistance, who otherwise don't have resources to provide for medications. There is very, very good evidence developed by the Centre for the Assessment of Devices and Technology in Health, which is a well-known Canadian institution, who last year published a paper showing that the government would save large sums of money if it provided these pharmacotherapies at no cost to smokers, given their calculated consumption of healthcare resources later on. I would have predicted that if it had not been for the recession that occurred in 2008 and the recent economic vibrations, that probably a number of provinces, as some have, would have moved to provide cost-free pharmacotherapy. In La Belle Province, in the province of Quebec, every smoker is entitled to a full, albeit fixed dose course of pharmacotherapy for smoking cessation once a year at no charge.
Next question?
Would pregnant smokers also be able to use the patch and the gum, or do they have alternative techniques for that?
So, excellent question. I don't know whether you were here when I talked about how pregnant women rate of metabolism of nicotine increases, making it arguably more difficult for a woman to stop smoking when she becomes pregnant than it would have been when she was in a non-pregnant state. So I also want to say that I don't see pregnant women anymore in terms of where I work and so on. But absolutely, if a woman is pregnant and still smoking, both she and her baby are much, much better off receiving NRT. And there's abundant evidence about this from a variety of sources. And unfortunately, what well-meaning health professionals have done in the past is said, gee, you really should try your hardest. Let's see how you do. Let's do this. Try over the next 6 weeks, over the next 8 weeks, over the next, you're pregnant, you really want to stop smoking. And only then, after it's 3 to 4 months into the pregnancy and the mother has been unable to stop smoking, when they say, okay, well, we'll think about using NRT. What we know is that the most critical time for the brain development of a growing baby is in the first 3 months of that pregnancy. So if a woman is smoking during the first 3 months of the pregnancy, I think you can make the argument, and I'm prepared to make it, and we'll make it, that it's far more important that you begin smoking cessation pharmacotherapy as early as possible so that you minimize the damage that would otherwise occur to that growing child's brain. One of the things that contributes to that damage is carbon monoxide. And when you smoke cigarettes, you dramatically increase the amount of carbon monoxide in your bloodstream. As you may know, carbon monoxide kicks oxygen off the red blood cells, which normally carry it around. But what most people and most physicians don't know is that the carbon monoxide concentration in the baby is about 5 times that in the mother. And so this baby's developing brain is being starved of oxygen at a very critically important time. We also know that children who are born of mothers who smoke during pregnancy have a whole array of developmental, academic, intellectual, and social problems later in life. They don't learn to read as quickly. They don't learn to walk as quickly. They tend to have higher rates of attention deficit disorder. They tend to have higher rates of opposite, of a whole variety of neurophysiologically related conditions, all of which I would speculate, and this is speculation, are related to the fact that their brain was compromised in that early stage of pregnancy when maternal smoking continued. So that's a very long answer to a very fundamentally important question. Yeah, I think it's very important that we be much more robust in terms of helping mothers who are pregnant stop smoking.
One more question as we're about to wrap up, right here.
I was just curious, several years ago, there was a social marketing campaign, I'm pretty sure it was called Just Do It or something like that. I think it was to quit smoking. I just wondered if it was effective, and if it was, why isn't it still happening?
So there have been a number of social marketing campaigns over the years that have had some impact. And I think they were helpful in sensitizing the population to, particularly in terms of making them aware of smoke-free environments and the hazard represented by secondhand smoke and so on and so forth. By and large, the evidence is not at all clear that having, I am Joe's one, or if you stop smoking, all kinds of, if you don't stop smoking, hundreds of horrible things are going to happen to you, are necessarily very effective. Because we know that the overwhelming majority of smokers know why they shouldn't smoke.
There was something that was different. I think it was called Just Do It. It seemed to target youth. And it was like really upbeat, and the message was pretty powerful. I remember listening to a speaker who talked about the effectiveness of social marketing. And to me, I think he was actually behind this campaign. And certainly it looked like it would be a really good, powerful message, and it just seemed to die.
Well, the most effective advertising and communications oriented towards youth are what are called tobacco industry denormalization messages. And those in California and Massachusetts and other states, which led the world in reducing teenage smoking, used these kinds of strategies. And they basically pointed out to teenagers that there were these scheming, scurrilous flea bags earning gazillions of dollars trying to get them hooked. And knowing that getting these people hooked was going to cause all kinds of health problems. Those are very, very effective campaigns. Now, governments, particularly our current government, are not particularly interested in that kind of growth. The other most powerful incentive to reduce adolescent smoking is price. So if you increase the price of tobacco products through taxes or otherwise by 10%, in adults that causes about a 4% decline in smoking. In adolescents, it causes a 14 to 18% decline in smoking, which is one of the reasons why the contraband tobacco thing is a real problem in terms of teenage smoking, and why it probably is the first challenge we should address.
But is it not increasing now with youth, smoking in youth is, I think, increasing?
No, actually it's not. And there's good data from the most recent, what's called CTUMS, Canadian Tobacco Use and Monitoring Survey, that shows we're actually we're doing not a bad job. We could be doing a whole lot better, but it's not as dismal as people like to make out.
All right, and I think we're going to wrap up with that, but I'd like to just finish with one final question with our former smoker, Fabien, if I can ask, are you still going down the elevator and climbing back up 12 stairs, or are you long past that now?
Sometimes I do. but not because I feel like I smoke. Sometimes I just need to walk and to get some frustration out. It's not because of smoking anymore.
Excellent. Good to know. Well, that's a good way to end this evening. Thank you very much. And of course, this evening was put on by the Ottawa Heart Institute, and the University of Ottawa Heart Institute, and the Canadian Institutes of Health Research. Thank you very much for coming out tonight. Hope you got some useful information. And of course, the panelists are still around for a few moments, so if you have any more questions you'd like to ask them in private, feel free to do so. Thank you. Thank you.
So I've got a few thank yous. First of all, I want to thank Annette, who brought a degree of poise and professionalism to our session this evening, for which we're very grateful. Thank you very much for doing this. And if I can let you into if I can violate a certain personal confidence, Annette typically goes to bed at 6:30 at night because she gets up at 3 o'clock in the morning and she can dazzle you on your television screens in the morning. So she's way beyond her time. And we're very gratified that you chose to be a part of our session. Thank you for honoring us with your presence. I do want to thank Dr. Levy, who unfortunately had other commitments, Ms. Gerner. I do want to thank particularly Fabien, who's been such a gracious co-conspirator with us and on many occasions as we speak to medical students, as we speak to public audiences, and your assistance and insights are very much appreciated. And to my colleague, Dr. Tulloch, who's, as I mentioned, doing groundbreaking research and is just one of the assets that we enjoy at the Heart Institute. Thank you very much, Heather. And the personal confidence that will break here is that not only is Heather an incredibly intelligent, insightful researcher, she's also a hell of a synchronized swimmer. And the things she just does. There are a group of people back at the Heart Institute who, some of whom are here, some of whom are flying back or trying to fly back from New Brunswick, and I'd hope to be here with us this evening. Dr. Bob Reed, Carrie-Ann Mullen, Debbie Aiken, Lisa, who's done such a marvelous job in organizing this event this evening, and all of our staff who are involved in the Ottawa Model Smoking Cessation. Some of them are here, and their expertise and their energies are unparalleled, and they're just doing wonderful things across the province. In particular, Manu, who's Mr. Audiovisual Computer IT guy. I call every week it seems I call, where's Manu? My iPhone's gone down again, and I don't know how to open up the app, and I forgot Manu's the guy that solves all of those kind of problems. Kate, Laura, Jana, they're with us this evening. Thank you so very much. And I always forget individuals when I do this, so please forgive me. I also want to thank our colleagues here at the Empire Grill. You guys have been great. I understand that it's and I understand that you've still got lots of those lamb thingies and little hamburgers, and you're happy to make up little boxes for people to take home and freeze and all that sort of stuff. Yeah, awesome, right? So this has been a very nice, relaxed kind of evening, and I thank you all for coming, and I thank everybody for helping make it the success that I hope it has been for you.